In this edition of Generations, we talk about the silent killer sepsis and how Wales in the United Kingdom is finding new ways to help identify the problem and educate the public about it too. Do you know what your cholesterol numbers are? We talk Cholesterol 101 with a registered dietitian about those and how we can manage our cholesterol. And Judy Jenks from seniorcenterct.org talks about your primary care provider, or what used to be known as the family doctor. Hello, I'm Brian Scott Smith and welcome to Generations, a new podcast for people of your generation. Sepsis is a medical condition that has been hitting the headlines more and more recently. But what exactly is sepsis and why should we be so concerned about it? Take a listen to this. So joining us on the Generations podcast is UK news anchor and reporter Andrea Byrne, who works for ITV, a major news organisation in Great Britain. Andrea did a report about sepsis and joins us now to talk about that. Andrea, thanks for joining us on Generations.
Pleasure. How are you?
Very good, thank you. Tell us, from your sort of research and reporting, what exactly is sepsis?
Well, sepsis, actually, when you break it down, sounds quite simple, but obviously the outcomes, if not treated, can be incredibly complicated. So what happens is it could develop from something as simple as a cut or perhaps surgery, which you might have had. And what happens after that is it could manifest itself later, like something like a gastric infection or a chest infection. But the problem is people don't realise that it's something so complicated. They think that it's just a cut and they think that the cut might have got infected, but they have no idea that this might develop into sepsis. And they've got no idea that once they get a gastric infection or a chest infection, that this is actually sepsis. And you can understand why, because lots of the symptoms can manifest themselves as something that we might get with the flu or something far less serious. So if left untreated, the body then starts to attack itself, and that's when things can go really badly wrong.
So it's clearly a big issue. You've done a report on this, but just give us an idea, certainly in the United Kingdom, how big an issue is sepsis?
So I actually centred a lot of my research in Wales, because that's where I'm based. So I'll give you an example of some of the shocking statistics that we found in Wales when we were researching. So we found that there had been a 75% rise in cases in hospitals and a 78% rise in the number of deaths in Wales, which is staggering when you think about those percentages. And now, to be fair to those figures, partly that is because in Wales they have developed a new way of recording sepsis cases and treating sepsis cases in hospitals. So in fact, this is sort of due to the fact that they are a lot more aware of sepsis now. So that is good news. So bear that in mind when we're talking about this. But also when you look at figures for England as well over the border, you know, that's been just as staggering. And there's been a huge rise in hospital cases there as well. I think it's something like they've gone up, but they've doubled in the last 3 years. So it's not just Wales that's got the problem. This is a UK-wide problem. This is a world problem. And it's because we just aren't aware enough about the symptoms of sepsis.
Now, there was also a very personal note to your report as well. Sadly, your father lost his life, and sepsis was part of that problem. Tell us a little bit about that, if you would.
Yeah, so my dad actually fell ill. I remember him messaging me and telling me that he'd had what he thought was a stomach bug. Now, I don't know whether that was actually the start of the sepsis or that it was just coincidence, and I don't think we'll ever know. But from what I know now about sepsis, it could well have been that that was the sepsis starting to manifest itself as a gastric infection, and it could have been that he'd had a cut or something previously which had led to that. Sadly, we'll never quite know exactly what caused the sepsis in the first place. And this was just before Christmas in 2016, and he went into hospital and then had an abscess removed from his neck, which is where the infection was gathering. And sadly, he was then in a coma which he unfortunately never came out of. So he died on the 17th of January 2017, and his body just couldn't fight the infection. And he's just one of, a huge number, as I've said, looking at those figures, which I mentioned earlier. And this is a worldwide thing. This is, and a lot of this is also due to the fact that part of the reason these figures are going up is we're all becoming more antibiotic resistant as well.
Yeah, I was going to say, this can be treated, but obviously has to be medically treated. But of course, yes, it doesn't matter where we live. We all seem to want to throw antibiotics down our throat, and there's the antibiotic intolerance, which has sort of started to manifest itself. I'm guessing, does that make it a little bit harder possibly for treatment?
Yeah, I mean, I think it means that it is harder to treat, and sometimes there's so many different variations of the infection that they have to try all sorts of different antibiotics. I know my dad was on several different types of different antibiotics throughout the time he was in a coma, just to try and boost that fight. And for him, it ended up infecting all of his organs, and he took a very fast decline. But what's really important with sepsis is that it's caught early, and those antibiotics, the right antibiotics, are administered in what they call an initial golden hour. So that just shows you how much time you've got. The key is to treat it like a heart attack or a stroke, and we all know how much attention, emergency attention, that needs. The important thing also is not to be so gloomy about this, is if you do catch sepsis early, if you can treat it early, then it's very manageable. But it's if you don't, when things can go wrong.
I'm sure there are many, many different symptoms, like so many other conditions that we can get. But can you give us a bit of an idea of some of the symptoms which would perhaps strongly suggest that sepsis could be playing a part in your bad health?
Yes, the symptoms, yeah, as you say, are very varied. But if you think of the word sepsis, and we take the initial letters of that word, there's the Sepsis Trust here in the UK have quite a good way of remembering those symptoms, or at least giving you a trigger for those. So S is for slurred speech or confusion. E is for extreme shivering or muscle pain. P is for passing no urine in a day. S is for severe breathlessness. I, it feels like you're going to die. So really that real sense of doom. And S at the end is for your skin being mottled or discoloured. And yes, you can apply a lot of those things to a lot of different things, and I appreciate that. And that is why it's very, very difficult to define. But the important thing is the campaign they run over here in the UK is just ask. Just ask, could it be sepsis? It's a simple question, but it's one that could save a life.
I think it's very good advice, isn't it? At the end of the day, I think we concern ourselves that maybe it's nothing and that we can get over these things. But like you said, there's nothing better than actually getting, medical advice. Certainly in the United Kingdom, people have access, to sort of online services or their doctors, and the same, really worldwide. There's really no excuse for sort of like ignoring it and not seeking medical advice, is there?
No, and to give you an example of how easy it is to let it slip by and not think it's anything serious, I interviewed a lady, an incredible lady actually, called Jane Carpenter, who lives here in Wales. Now, she lost 3 limbs to sepsis, and this was over 2 years ago. Now, she's a nurse. She was a nurse of 20 years, and she had a chest infection. She didn't spot the signs of sepsis in that chest infection. She didn't realise that she had sepsis. So this is a nurse we're talking about, and she was very clued up on everything, but still she didn't realise that this was sepsis. And the signs weren't spotted soon enough by the health professionals either. And in her opinion, she thinks that maybe there was a point where that could have been prevented. So she ended up in hospital. She was in a coma, and her organs were just being overwhelmed. They were being reinfected, and her body went into septic shock. She needed urgent surgery to save her life. And she is doing brilliantly now. And she's such a fantastic lady, and she's an avid fundraiser and campaigner for Sepsis Awareness. But her story just shows you just how crucial it is to catch it early, and how hard it is also to define. But if she had known to ask, just ask, could this be sepsis? Maybe they would have identified it sooner.
And since you've done this report, I mean, have you just been following up, when you can, to see how things, maybe are progressing at all? You mentioned that obviously, there are organisations who are pushing forwards like campaigns like Ask, and clearly in Wales, where you are based, a very large part of Great Britain, they're attempting to do things. What is the sort of like the updated position from what you can glean?
Interesting. Really interesting. I met another lady called Eve Lightfoot, and she actually won an award not too long ago for being Nurse of the Year for the work she's been doing around sepsis awareness. And what she recognised, having worked in A&E but also in the community, was that evidence showed that 70% of sepsis cases actually start in the community. It was all very well having a sepsis early warning system, which people in the health profession were aware of in hospitals, but if people in the community weren't trained up on that, well, 70% of cases could be slipping through the net and ending up in hospital, and they might not need to be there, and certainly wouldn't need to be getting more serious. So she pushed to develop the same scoring system in the community and trained up district nurses and other nurses to use this scoring system. So that's why she won this award, because she really is saving lives. So that's brilliant that that's being done and being supported by the government as well. So that's really great. Unfortunately, when I interviewed the health minister here in Wales, one of the things he isn't keen to do at the moment is support and help fund a public awareness campaign around sepsis, which I think it's fair to say a lot of the charities here and those who are really campaigning for that hoped would happen. But he is doing a lot of other work around it. Hence why the figures, as we were talking about earlier, are so much higher now, because there is more work done to identify sepsis in hospitals and in the community. So that is good. They're also setting up a network to help those who have survived sepsis, people like Jane, and create a sepsis index so they can find out a lot more about those people and what's happening with them. So a lot of work is being done. There's also a treatment bundle they've brought into hospitals called the Sepsis 6. So I think it is being taken seriously, and I'm really pleased to hear that. Yes, a public awareness campaign I think would be great, but there's reasons why he says at the moment he doesn't feel there's enough evidence to support that.
Well, Andrea, it's been great talking to you, and obviously a very serious subject, one that's very close to your heart, but also it sounds as if things are slowly starting to get better, and certainly there's some great nurses in Wales who are doing an amazing job to help raise public awareness, and we can only hope that that continues not only in Wales and Great Britain, but also, as you said, it is something that is a worldwide problem. So let's hope that these sorts of things can be taken on across the planet, and less people end up dying from sepsis.
Yeah, I hope so too. Thank you for having me.
That's Andrea Byrne from ITV Wales joining us on Generations. And for more information about sepsis, visit sepsis.org. Now, cholesterol. We hear so much about it and the numbers we should have, but what does it all mean? Take a listen as we take you through Cholesterol 101. So joining us now on the Generations podcast is Shannon Haynes. She is a registered dietitian at Bacchus Hospital. Shannon, thanks for joining us on Generations.
You're welcome. Thanks. Good to be here.
So tell us, cholesterol, what is it and why should we be concerned about it?
Okay, so cholesterol, we actually do need cholesterol. I mean, some people think it's the bad thing as total, but it's not. It is, a fatty substance found in our blood. And your body does make cholesterol naturally through the liver, and then you can also get cholesterol from what you're eating. So your body needs it to form some of its cell membranes, and it also needs cholesterol to fully utilize vitamin D. So you need some of it, but sometimes we have too much of it in our bodies.
Can you give us a rough idea of what the sort of numbers should be for somebody's cholesterol? And, if it's high, what does that actually mean?
Your total cholesterol, that used to be very strict because cholesterol has kind of evolved. And since I started practicing, it used to be, over 200 is bad. You need to go on medication or a special diet or something. And what they're really realizing, and within cholesterol, we have our LDL and our HDL, which stands for low density lipoproteins and high density lipoproteins. The LDL are called the bad cholesterol. And I had a student once help me remember that. They were so funny. They said, well, I remember it because it's L for lousy. So that's how you remember. And you want the bad cholesterol. You don't want to have a lot of that one, because what that one does is it actually will encourage your body to line your arteries with fat, and it will cause the arteriosclerosis, where it can lead to the hardening of the arteries. And that's when you have heart disease and can have heart attacks. The HDL, the good cholesterol, you want to have a lot of that. And so beyond just the 200, the HDL, they like to see it over 45 for men and over 55 for women. And the bad cholesterol, they just want you to really kind of have it under 70 is a great goal. But the HDL, just to define that too, what that one actually does is that goes through the body, and it actually will kind of pull the cholesterol, the fat that has started to attach to the side of the arteries, and it will help to clean out the arteries almost. So that's why you don't want to get too worried about your total number, but it's more important to look at the difference between your HDL levels and your LDL levels. There's also that ratio too that they give you on that lab value that will tell you, what is your ratio. And your ratio says how much of your cholesterol is made up of the bad cholesterol. And that one, you want it to be 4. 4 to 1 is a high ratio. So any higher than that, that means they say that you're at risk of heart disease.
So, unlike sort of certain conditions where we can feel unwell, if we sort of have like a cholesterol problem, will people know about it, or will they only know about it when they've maybe gone to see their doctor and, the doctor for some reason has decided to have them tested for cholesterol?
Well, you actually probably won't have any symptoms. I mean, if you have like a blockage in your arteries, where you already have full-blown cardiovascular disease bordering on a heart attack, a lot of people will say they feel like they don't have a lot of energy. But just to have high cholesterol, it doesn't mean that you have heart disease. Just you probably have no symptoms. And it's interesting because a lot of this is genetics, and how much cholesterol our liver makes is really genetic. And it's also genetic on how you can affect your numbers by if you're eating foods high in cholesterol. I actually was doing some more reading on that today because it keeps changing. And what they're really finding is like things that we used to eat too much of, like the eggs, not too much of, but we used to have daily, the eggs, they used to say only have 3 eggs a week. And now they're finding that those foods that just have cholesterol in them, but not saturated fat, those don't affect your cholesterol anymore. So they kind of try to encourage you to limit your saturated fat to actually help lower your risk of heart disease.
So when we're talking about saturated fat, just maybe one example, I assume you're meaning something like red meat, because red meat has a lot of saturated fat. So should we be looking to reduce the amount of red meat we eat for maybe white meats or something like vegetables instead?
Definitely. We want to limit, so the sources of saturated fat would be red meat, and then like the dark meat in poultry and the skin on the chicken and the turkey, and also your high fat dairy foods are also sources of the saturated fat. Pork, the fatty parts of the meat. If you're buying lean, it's significantly less. But yeah, your sources of saturated fat is all from only animal sources, except for palm oil and coconut oil are the only vegetable sources. So that's why they tell you if you're going to cook, use olive oil. If you're going to, maybe if you want to bake something or you want to use canola because the olive oil tastes too strong, then you can use canola oil. But overall, those the monounsaturated fat sources, like from the vegetable sources like olive oil, avocados, walnuts, and then our fish, our fatty fish also have the unsaturated fat. Those will help improve your good cholesterol. So you want to have those more often, if not daily, and then really limit the saturated fat. The American Dietary Guidelines, recommends that less than 10% of your fat for the day comes from saturated fat.
Now, what about as we age? I mean, is cholesterol more of a problem as we get older where maybe we're less mobile or we take less exercise? I mean, what's the situation there with cholesterol?
I mean, I think it's definitely one of those things where over time, if you're living with high cholesterol, it can cause damage to your arteries. It sort of, encourages it. But if as we age, I think it still is important. The other thing that I forgot to mention was that they're really finding that some people are what they call hypersensitive to what they're eating and it affecting their cholesterol levels, their blood cholesterol levels. So that's why I have some doctors I work with that, they say, well, you can try diet, but I'll probably have to do medicine because only a certain number of the population, things like 20%, will respond to the altering of the diet. But, so as we age, if you already have heart disease, I always feel like it's a good idea to try and do what you can to improve the healthy status of your arteries, especially people, maybe they've had a bypass surgery. So, you have brand new arteries there. So let's try to take good care of them and not let the damage occur that we had happen in the past. But I don't necessarily think it's ever too late to try and do what we can to improve that. Some other ways to lower your cholesterol is also through exercise. That's another way to try and help lower it, besides, medication and watching what we eat.
And when you say exercise, I mean, again, people, I think, suddenly hear that word and think, oh my God, I have to go to the gym and I have to exercise for like an hour and a half. But what is the reality? Could it be something as simple as maybe taking a half-hour walk every day at a medium pace?
Yes, definitely. And because it doesn't mean that. And exercise is also age dependent, in that, what might be exercise for a 19-year-old girl is probably not the same thing that's what's considered exercise for a 75-year-old woman. But I think just something that gets your heart moving and pumping and your blood flowing. So that could be, a nice a walk that's not, super slow, but you can have a conversation with somebody next to you, but you don't have to be too winded. And doing that for 20 to 30 minutes, even if you can do that, whatever, 3 to 5 times a week. Definitely more along 5 days a week is a great goal. But I'll tell people a lot, even if the weather's bad, go to Home Depot or one of those big box stores and walk around there, because it's nice, because it's big, the ground is flat, and you're safe to not worry about falls. But when it's nice, like now in the fall, we do have a lot of places like between Mohegan Park or Paquonic Plains down in Groton, or some kind of nice flat tracks. Those are also great places to walk.
Shannon Haynes, qualified dietitian at Bacchus Hospital. Thanks for taking us through Cholesterol 101 today on Generations.
Great, thank you.
So joining us as ever is Judy Jenks from seniorcenterct.org. Lovely to see you as usual, Judy.
And it's great seeing you again, as always. We always have plenty to talk about.
We do. What ode to whatever are you going to be talking to us about this month?
Today we're going to talk about primary care providers because things are different than they used to be.
Excellent.
Again. So once upon a time, we went to the doctor for everything, and it was called our family doctor. And now they call that our PCP, or primary care provider. They can now be an MD, a physician's assistant, or a nurse practitioner. We go to them for a yearly exam, a cold, or other common medical problems. And if you don't have a PCP, it can become very hard to get any other health care. We need a primary care provider who fits into our insurance plan. Will it be available for the majority of our health issues, and who we have trust in, someone we feel comfortable talking to. Then the problem arises when our trusted doctor retires or moves, or our insurance no longer covers that doctor, and we need to find somebody new. Generally, we will start by asking our family and friends who they use, what they like and dislike about that provider and their practice. Then, is the provider covered by our insurance? Are they part of the network? Are they taking new patients? Because sometimes the practice is full. You also can ask other doctors for recommendations. You might be seeing an allergist, and you could ask them, or you can ask your dentist or pharmacist as well. Then the next step is, are the primary care providers you're considering easy to get to? Do their office hours work for you? Again, double check that they're part of the network of healthcare you're already in. Once you have narrowed it down to 1, 2, or 3 primary care providers, now is the time to schedule an appointment. Go for a visit and see if you like them. Did they take enough time with you? Did they get interested in you as a person? Did they answer your questions? Was the office staff helpful and friendly? If the answer is yes to the questions that are important to you, then you're all set. Otherwise, keep looking. Don't settle. This is an important decision. Perhaps one of the most important decisions you will make. Remember, not everyone likes the same person or the same professional. That's why there's so many to choose from. Find the doctor and the practice that fits you so that you are comfortable when you are the sickest, knowing you're getting the best health care available.
And it is absolutely so important because it's critical to have that relationship, and it doesn't matter at what age. I mean, it is such a personal thing, our health, and if you don't get on with your health provider or your doctor, it just doesn't work.
No, it doesn't work. And so many times if you don't have that relationship with your healthcare provider, you're not telling them what's really going on with you, and the situation can get much worse.
Yeah, absolutely. I mean, as I say, it's the trust, but also that ability to communicate as well. And, some of us aren't always as good at, being honest about things as well. And like you said, so again, if that relationship isn't working, the full picture isn't coming out, and then you're only a fool to yourself because you're not doing your own health any good by not having those proper conversations.
Yes, and this is all about you. If you don't do the homework and you don't make the effort and you have a healthcare provider that you're complaining about, it's your fault. It's not the healthcare provider's fault.
No, absolutely. This edition of Generations, whilst this goes out, Medicare open enrollment will start. In November, we will be talking a lot more about Medicare because, of course, that continues to evolve. So I'm sure we'll probably touch on this subject again. But one thing I did want to mention to you, because we're always talking about technology and our changing attitudes and uses of technology. Telemedicine is something I'm reading a lot more about, where you can now, in certain circumstances, still not in every circumstance, but you can actually get in contact with a doctor through the webcam and the miracles of the internet and have that conversation that way, if you're, I suppose, unable to get to an office, or if it's more of an emergency thing. What do you think about that?
Or you also could be using it if your provider has moved or retired and you haven't found one that fits you. Also, you can do a huge amount of research on the internet. Don't believe everything you read. But if you have questions about a condition, you can do research and educate yourself so you have better questions when you go back.
But I think, having that ability to also, almost have like a video chat. So
Yes.
Again, if you can't make it to the doctor or it's an emergency sort of situation, or again, distance could be, an issue for you. As you say, maybe your doctor's closed down and, this actual facility is quite a few miles away from where you live. I think it's interesting. It'll be interesting to see how it evolves because, again, going back to what we just said at the very beginning of this, it's very personal. Are you going to feel that you want to have a chat effectively, almost like FaceTiming your doctor? Is that something that people are going to take up?
And I also think it could be really good, like when we talked about location. In some parts of this country, you can be an hour or more away from a healthcare provider. So that would be excellent, maybe even for like checkups if you're a relatively healthy person. You're right. This is going to evolve and change dramatically the way that we're doing things.
Yeah, absolutely. Well, as always, thank you ever so much. And like we said, next, the November edition, we will be hitting it hard with Medicare. Very, very important subject for so many reasons, obviously always changing as well. So we'll look forward to having that detailed conversation about Medicare. But in the meantime, stay healthy and we will catch you next edition.
Okay, you too. Take care.
That's all from this edition of Generations. Don't forget to visit seniorcenterct.org to find out what's going on in your neck of the woods. And if you want to send us a topic to talk about or want to be our guest on the podcast, drop us a line by visiting the seniorcenterct.org website. Go to the bottom of the homepage and click the How to Advertise with Us link to get in touch. From myself, Brian Scott Smith, thanks for listening. We'll catch you next time.